I am not introducing our speaker this morning. I am introducing the introducer of our speaker. It's Anna Valama. She is our CBHD research scholar. She holds a double MA in Old and New Testament from Talbot School of Theology, and she is currently and officially a PhD candidate in Old Testament here at Trinity. When I did my PhD, as soon as you passed comps, which is not the same thing as finishing them, ask me how I know. As soon as you pass comps, you're considered a candidate. But here, you have to also pass your dissertation proposal. So she has done both of those things and is now officially a PhD candidate. She began as an Orr Fellow with us 2 years ago, and last year moved into the role of research scholar. She is a creative thinker, a hard worker, and a true extrovert. I think even she is willing to joke about how did she get admitted into an academic program like this, being so extroverted, because most of us, as you all know, are either extremely introverted or what a friend of mine calls high-functioning introverts. But she is a true extrovert, and if you've met her, you know that. And it is a wonderful thing. So Anna, please come and introduce our speaker for this morning.
Thank you, Matthew. It is true, I am a true extrovert, and so conferences like this are my delight, right? It's the combination of amazing people and big ideas, and so I always grieve when this ends, and I have a little low after this, so I'm gonna feel this after. There's something very special about a place like this, a place where the room is filled with people who love God deeply and seek to protect human dignity as a result. This year in particular, the intersection between the sessions has struck me. Perhaps it's the urgency of the times and the issues under consideration, but questions like what it means to be human are consistently coming up in both the parallel paper sessions and plenary sessions. So when I read Farr Curlin's abstract, I was excited to see yet another intersection into important questions. We've been asking the question of what it means to be human. He now presses us into the question of what is medicine and what it means to be a good doctor. And he's aptly equipped for this task. He's a Josiah Trent Professor of Medical Humanities in the Trent Center for Bioethics, Humanities, and History of Medicine. He's also the co-director of the Theology, Medicine, and Culture Initiative at Duke University and has worked to bring attention to the intersection of medicine, ethics, and theology. In 2012, he helped to found both the University of Chicago's Program on Medicine and Religion and the annual Conference on Medicine and Religion. Started in 2023, Dr. Curlin works with colleagues across North America to develop the Hippocratic Society, an association of students and practitioners dedicated to forming clinicians in the practice and pursuit of good medicine. He is co-author with Chris Tollefsen of The Way of Medicine, Ethics and the Healing Profession, as well as more than 150 articles and book chapters addressing the moral and spiritual dimensions of medical practice. So join me in welcoming Dr. Curlin.
Thank you, Anna. It's a privilege to be with you this morning. Greetings from all my colleagues at Duke's Theology, Medicine, and Culture Initiative. CBHD has been a really important institution and a community in fostering attention among Christians to the big things that are at stake in the world of healthcare, and I'm grateful to be among you. I want us to think about whether there is a way of medicine for Christians, and what is that way? We at Duke have coming to us for our Theology, Medicine, and Culture Fellowship young people who are on their way to practicing medicine. Most of them are going to be doctors, but most but not all are going to be doctors. And they come either generally between college and medical school, or they take off a year or two during medical school to study with us. And why do they come study with us? Well, if you listen to them, many of them would say they come because They understand medicine and have felt drawn to medicine, called to medicine, because it seems that medicine is for them part of their calling. It's part of their calling as Christians, as followers of Jesus. And then they find, particularly those that have been in medical training for a few years, they find at some point that it's not obvious how you go on in American healthcare today into the future of healthcare, as we've seen in the conference focus, faithfully, with integrity as a Christian. Sometimes this dis-ease or these questions are expressed in the language of personal and professional, or personal versus professional. So they might be asking, how do I continue to participate in the medical profession to which I thought I was called while protecting my personal integrity as a Christian? Or how, they might ask, do I balance my personal and professional identities? It seems to me that the phenomenon of burnout, which afflicts both medical trainees, as probably many of you know, in high numbers, and also medical practitioners, is itself a symptom of losing touch with how medicine fits into one's calling. And we see this among many of our hybrid students. We have a program that designed for practicing physicians who want to study Christian tradition but continue working where they are. And I'd say the average person in that program is a middle-aged doctor who has come to a point where they're just not satisfied with what they find themselves doing and how they find themselves talking and what they seem to be structurally fitted into in the world of healthcare. They have always understood the work of medicine as a part of their calling and as having deep meaning, but they're just struggling to find how it is anymore sufficiently, and they're longing to recover a vision for how to go on in healthcare faithfully as a Christian. Now, what TMC does is basically invite people to turn to the resources of our story, the story of everything, the story of creation, fall, and redemption, the story of the people of Israel, and of Jesus, the Messiah, our Savior, and of the church. And turn to that to understand what medicine is and is for, and how it fits into the lives of Christians. Now, you can't answer these questions, what is there a way of medicine and what is that way, I think, until you can answer the question, what is medicine? As Anna pointed out, that's the question I want us to think about. What is medicine? And there are, I think, two broad understandings of what medicine is that operate in the contemporary world of healthcare. And they give contrasting answers. Regarding many parts of the practice of medicine. In one sense, the question, what is the slide? There's a little thing here that says, change your slide. In one sense, the question, what is medicine, seems simple and straightforward to answer. Surely medicine is the practice of healing humans, of preserving and restoring the health of those who suffer injury and illness. Surely good medicine is both motivated by concern for the patient's health and guided by the medical practitioner's expertise in the ways of the human body. And health seems equally obviously an important, even an essential aspect of human flourishing. If you are sick or suffering from a health-related impairment, you are just not as well off as you could be if your health were restored. I dare say there are folks in this room today who are suffering health impairments, acute or chronic, and are conscious, it's just part of your experience, that insofar as that's true, you experience yourself as not being as well off as you could be, all else being equal, if your health were restored. This account of medicine makes sense, it seems to me, of what medical practitioners are doing when they're most obviously practicing medicine, and what makes them medical practitioners rather than practitioners of some other art. When I say most obviously practicing medicine, if I just asked everyone here to think of a doctor being a doctor, I dare say what will come to mind is some kind of image of someone up close to someone else, and someone else is injured or sick in an obvious way, and they're acting in some tangible way to try to preserve or restore them to health and to accompany them in their illness. This account of medicine can give rise to important norms of medical morality, ethical norms to guide medical practitioners, such as do not act contrary to a patient's health. Do not let your concerns for your patient's health be subverted or by prejudice, by apathy, or self-interest. Give to your professional practice the attention, time, and energy needed to shape your life as a person devoted to excellence in this way, in this practice, in this art of preserving and restoring health. With my colleague Chris Tollefsen, who's a professor of philosophy at the University of South Carolina, I've argued that this conception of medicine and its morality, which we call the way of medicine, should guide medical practice. That medical professionals must act in accordance with the norms of the way of medicine, so understood, for their medical practice to be truly congruent with human flourishing, with human good, for it to be reasonable. But this vision of medicine finds competition in an approach that we call the provider of services model. This model, which has steadily grown in influence over the past half-century, assumes that medicine comprises a set of technical skills and capacities that professionals are to use primarily in service to a patient's autonomously chosen preferences and goals, even if those preferences and goals detach from or even directly contradict the patient's health, otherwise understood. The norms of the provider of services model are rather different than those of the way of medicine. In the provider of services model, an intervention is medically indicated. It's something that a medical practitioner ought to do, as long as that intervention is legal, effectively brings about the patient's goal, and is freely chosen by the patient. A practitioner of the way of medicine might object, for example, to physician-assisted suicide or euthanasia as acts that contradict medicine's fundamental commitment to patient health. But proponents of the provider of services model increasingly will argue that where such practices are legal, so is that true in Illinois yet? Not yet. That's right. It was blocked this year again. But it's, knocking at the door. Where it's legal, then physicians should provide these practices, refer for them, or if unwilling to do so, they should exit the profession, because in refusing to do so, they're effectively refusing to fulfill their obligations as medical practitioners. Just to give you a more mundane example of the prominence of the provider of services model, it's infiltrated all across medicine, become a habitual way of thinking and acting. I recently heard a few weeks ago a talk. It was a quite compelling talk about innovations in hospice care. By the way, I work in hospice and palliative medicine. Innovations in hospice care to allow patients on dialysis to receive some dialysis while in hospice. Without making a long story, generally people on dialysis can't be in hospice because hospices have to pay for all their costs, and dialysis is very expensive. So people try to create programs and get approval, governmental approval, for allowing people to get some dialysis while in hospice. I think on the whole it's probably a good idea, these programs, but what struck me was that in presenting this, the whole proposal and why it's a benefit and why we ought to do it was advanced in the language of this being patient-centered, and patient-centered was interpreted as facilitating patient choice, patient options, patients being in control. All that language was used. People said, there's lots of patients who want this. People want some control. It's an option that they value, therefore we should do it. More and more, the expectation that physicians will provide the services patients request is framed as a matter of patients' rights. The patients have a right to such services, and the physician has a corollary obligation to provide them. Of course, few physicians practice in ways that fit fully into either of these two models of medicine. There's no one practicing in a way that's kind of governed by the provider of services model that thinks that health is unimportant. At least I haven't encountered anyone like that. And many dedicated physicians who practice according to the way of medicine, I think, provide occasional services whose connection to health seems remote. Nevertheless, the two models of medicine provide a helpful way to understand a number of conflicts in medicine, such as those, for instance, between defenders and opponents of conscientious objection in medicine. When a patient requests something, I was going to say or demands, but let's just say the patient requests something that a physician finds morally problematic. This is often framed as a matter of the physician's personal and private conscience intruding upon his or her public and professional practice. Refusing such requests seems to many to violate professional boundaries. That personal convictions are fine, they're good, they're great, so long as one recognizes that they must be kept in their place and they must be set aside when taking up one's professional role. This is, I will say, the dominant way that young people, in my experience teaching medical students every year, the way they understand the personal and the professional so-called aspects of their work. And that's true among even Christians. This has become a habitual way of thinking and talking. But from the standpoint of the way of medicine, these refusals by physicians look quite different. They look like physicians refusing to act contrary to their commitments as physicians. They look like physicians insisting they must fulfill their profession that they have made to their patients, their colleagues, and the public, even when doing so, and maybe especially when doing so, requires saying no. So that's to say that in almost every case, conscientious refusals by physicians are refusals based on the physician's judgment that the intervention requested either is not required by or directly contradicts the patient's health or some other important medical moral norm. Bless you. We see this with refusals that do not appear controversial. So, for example, a patient presents to his or her clinician or physician, and the physician refuses to prescribe antibiotics for the patient's cold. Right? This happens all the time, and it's not controversial. Or a clinician refuses to prescribe opioids out of concern to avoid the adverse side effects of these drugs, which of course unfortunately, we did not pay enough attention to for a long time, but thankfully now are starting to. Again, a refusal based on what people understand as their professional commitments, not very controversial. These are not perceived as refusals where the personal trumps the professional, but instead as refusals in which one personally fulfills one's professional commitments. And I think, from the perspective of the way of medicine, the same pattern is true, the same dynamic is true with respect to more controversial interventions. So a young woman presents to her family physician, newly pregnant, and asks for a referral for an elective abortion. And from the vantage of the provider of services model, it's pretty obvious what the physician must do there, assuming abortion is legal in that context. It's legal, it's feasible, and it's sincerely sought out by this young woman, then you're obligated to either provide the abortion yourself or refer to someone who can. But from the vantage of the way of medicine, the first question you have to ask is, how is this thing that's being asked of me consistent with my commitment to this young woman's health? And those who refuse to refer for abortion, although they may, even in their own minds, be thinking primarily of something like a religious conviction, or just a sense of the dignity that we've talked about before, or how God is honored, as Matthew put it, the human beings, and how we must act in accordance with that dignity, fulfill that honor. It is also true that they are expressing a judgment that this action that is asked of them is contrary to their professional commitments, contrary to what it is they reasonably have professed as a physician or as a practitioner of medicine. Same thing with medicalized gender affirmation, just to give one other example. It's been on my mind quite a bit lately, and I've had the chance to speak about a couple of times recently. And for medicalized gender affirmation, a 15-year-old female presents, perhaps with her parents, to the doctor and expresses a gender identity of being a boy, and finding her body at odds with her true identity as a boy. And the standard expectation now under the provider of services model is effectively to ask, is medicalized gender transition, puberty suppression, cross-sex hormones, is that legal? Yes. Is it feasible? Yes. Sadly, there are the clinics who offer this all over the United States. Is it sincerely desired by this young female and or her parents? If the answer is yes, and if this young female perceives that her well-being requires actions to reshape her body or into the form that's more characteristic of a male, or to at least blunt the further development of her body into the forms that are characteristic of a mature female, then you are obligated to refer that person. And that is, of course, what we are told by the American Academy of Pediatrics and by the American Medical Association and by the Endocrine Society and American College of Obstetrics and Gynecology and many other professional associations, all basically following, talking in ways that only make sense if we take medicine to be governed by the provider of services model. So understanding disagreements within medicine as potential conflicts between the way of medicine and the provider of services model, this does not settle these disagreements, but I think it does help us understand the disagreements and what is at stake in them. There's lots more to say about the way of medicine. Happy to talk about it more, but let's turn to this question: is there a way of medicine for Christians, and what is that way? And the first thing I'll say is I think it begins with the way of medicine. The way of medicine for Christians, I think, begins with the way of medicine. Alan Verhey, a late colleague and mentor at Duke Divinity School, who also taught years at Hope College, in an essay on the Hippocratic Oath insofar as a Christian may swear it, wrote the following. The first lesson, by the way, the Hippocratic Oath insofar as a Christian may swear it arose early in the church's history, a few centuries in, when Christians basically took the Hippocratic Oath and adopted and amended it to be an oath that Christians could swear. So we weren't swearing to Apollos and Hygeia and Panacea, of course. And there were a few other modifications, but keeping the basic content of the Hippocratic Oath. He said, the first lesson of the oath insofar as a Christian may swear it was that Christian ethics does not disown natural morality. The Christian story does not force those who own it to disown either medicine as a practice or human rationality. The way of medicine in its basic structure has been embraced over history by Jews, by pagan Greeks like Hippocrates and his followers, and Romans, by Christians, by Muslims, and by many others. It is the vision of medicine that is implicit in codes of ethics like the World Medical Association's Declaration of Geneva, and frankly, all major codes of ethics up until revisions of those codes in the last half century. It's what makes sense of what nurses and physicians and other medical practitioners are doing at UNC and Duke and elsewhere when they're most obviously practicing medicine. When you think of a physician practicing medicine, again, you think of, I think, someone doing what is best described as attending to those who are injured or ill, seeking to preserve and restore their health. Where health is objectively defined. It's a bodily characteristic. It's not something that can be redefined by a person in terms of what they find desirable. So I think the first step for Christians is to embrace the moral commitments of and respect the limits of the way of medicine. And the central commitment in that is to act only insofar as your actions are consistent with a commitment to the patient's health. That's implicit in the language of the Hippocratic Oath and the broader Hippocratic corpus. It is centrally a part of, again, great medical professions through the centuries. And it's the fundamental, I think, commitment that makes a medical practitioner a medical practitioner. But for Christians, the way of medicine is markedly enriched. So back to Verhey. He says, the second lesson of the oath, insofar as a Christian may swear it, is that Christians concerned with medical ethics should have the integrity to set medicine in the context of the Christian story, to form, inform, and reform medicine. The first lesson stands against any premature sectarian stance, against opting prematurely for either a sectarian community or a sectarian medicine. The second lesson stands against any simple identification of a Christian ethic, either with universal and rational principles or with a professional ethic against, for example, sanctifying contract theory by identifying it with covenant. The task is to transform, or to put it less presumptuously, to qualify a rational ethic and a professional ethic by candid attention to the Christian story. So, for Christians, setting medicine in the Christian story is part of participating in God's redemption of the world, including God's redemption of the institutions and practices of medicine, which are ever in need of renewal and reform. And this happens not by displacing, or this Christian way is not by displacing professional medical morality with personal Christian values, which is what those in the provider services model want to say it is. That's not what's going on. But instead, it's by discerning the character of our world, including what it means to be human. And you can't do that fully unless you discern the reality of who Christ is. And what our world is like, and what we are as humans, as we've been talking about this weekend. And it involves embracing and developing the practices of medicine into what they can be if they are to fit that world and become more fully what they are meant to be. So, just give you a few examples here, and happy to talk more about them as time allows and interest indicates. First is that the Christian story gives us a better account of why we care for the sick. Caring for the sick is actually a perplexing activity in a strictly scientific, naturalistic worldview. Why we exert so much energy caring for those who are either beyond the point of reproduction or whose reproduction is going to potentially diminish the fitness of the gene pool. And yet everybody knows it's a good thing to care for the sick. Christian story makes sense of that. It makes sense of it in terms of the claim that all humans are made in the image of God, that we are made in the image of the one who is the image of God, that we have dignity, that, to adopt Matthew's language yesterday, which was new for me, and I'm still thinking through its implications, that we care for others because God has honored human beings, and God is present with all human beings. We see that in a really specific way in the New Testament claim, in the gospel claim, that Jesus shows up in those who are weak and sick. Matthew 25 or 26, Jesus says that. A story in which weakness is not despised but is honored, which was not true in the Roman world into which Christianity came as a dramatic surprise, as my colleague Kevin Rowe puts it. So Christianity actually gives us a lot better resources than the standard story for why we bother caring for the sick. It also gives us a better account of the practitioner-patient relationship. It gives us a reason for reverence, right? For resisting the tendencies to treat patients as machines, as abstractions, as statistics. If it's true that when you have visited the sick, the least of these, you have done unto Jesus, that somehow Jesus shows up to us in some mysterious but true way, because God, as Matthew was talking about, God's honor and glory is present in every human being, then that's a good reason to keep cultivating reverence. It gives us accountability, a story in which we recognize we're accountable not just to the data and to healthcare institutions' quality measures, but we're accountable to one another and to God. A way of resisting the habit of engaging patients through arm's length transactions between customers and providers where we will wield power to satisfy wishes or not. And instead animates and inspires morally committed efforts. The very thing we have in mind when we talk about making a profession, efforts to discern and act for the patient's good, and to find our own good in so doing, right? A way of actually setting aside language like work-life balance, and instead asking, how can my work be genuinely a part of my life and life-giving, because it's participating in and in pursuit of the good. The bottom line is Christian tradition offers ample resources to resist these endemic tendencies for clinicians to treat patients like objects and patients to treat clinicians like mere providers of services. It also gives us a better account of our obligations to the underserved. We have in Christianity, in the history of the church, we have this tradition that's developed that has been called the preferential option for the poor. It goes right back to the Beatitudes, Jesus saying, "Blessed are the poor," but it's repeated throughout the scriptures, Old Testament and New, throughout the history of the church, that the poor have priority for Christians because somehow in the poor, God has a particular solidarity with the poor. There are concepts like the universal destination of the goods that in the church's social traditions that emphasize that everything, because it's been created by God for all people, we're to look for always be looking for how the goods that God has made possible can be made available to all. And the notion of the common good, that set of conditions which make possible for everyone to flourish. We know from the scriptures that we're all joined into one body where weaker members deserve special honor. These are remarkable resources for animating, refining, chastening, guiding, inspiring the practices of medicine. And none of these is contrary to the way of medicine. Also gives us a better account of the limits of medicine. So Christianity gives us a story in which it makes sense to respect the givenness of our created natures. We know that we are created. We didn't just happen. And as those who are created, we reasonably ask, what are we? And how do we live in accordance with what we are, the reality of what we are, what kinds of beings we are? That, for example, will lead us to, I think, have a good reason to resist harming bodily health in pursuit of well-being, some kind of ephemeral self that is somehow free of the body, which is what this medicalized gender transition does. So it takes the objective good of the health of a human being and acts against it in pursuit of the good of something else that is like a self that's somehow detachable from that human being that's in front of you. It's a story that teaches us about patience and actually has practices to form in us patience, practices of prayer, practices of being still, practices of worship, practices of memory, of how suffering is a part of human life, and God dignifies those who suffer, and God lifts up those who are down, and God, his strength is made perfect in weakness. All of this cultivates patience and a posture of kind of gratitude for life and what's possible in it, for the health that we have, without grasping desperately, fearfully for what we don't have, or trying to escape the human condition altogether. Gives us resources for resisting the tendency to turn our lives into anxiety about the future and to look to medicine to alleviate our anxiety. Jesus says in Matthew 6, can any of you, by worrying, add a single hour to your span of life? It's a really good question for medical practitioners to consider as they set out imagining themselves as securing the future of people from bad things that will happen. St. Basil said that Christians should not get so concerned about their health that they turn their lives into one long provision for the flesh. And so it gives us a kind of check also on, Christianity does, on the hubris of medicine. Reasons to understand medicine as a gift, not an idol. To resist medicalizing human life willy-nilly, and instead humbly appreciate the gift of health and medicine without looking to either to save us. And the last thing I would say is that when you set medicine, the way of medicine in the context of the Christian story, we see that practicing medicine remains, despite all of its difficulties, and despite all of the ways it is prone to distortion, and despite all the obstacles that people face, it remains very good. It's a remarkable adventure. It's deeply meaningful. It's a fitting way to spend your life. And I think one of the things that's been most satisfying in my own work with our fellows in the Theology, Medicine, and Culture Initiative is every year, at the end of the year, we have a retreat, and we always have to give each fellow time to reflect on what's happened to them over the course of their year or two studying with us. And that if there is one dominant theme, it's that they have recovered confidence that a life spent practicing medicine is very good, that this work is very good. If you understand it well, and if you see clearly, and if you choose to trust the Lord and make choices according to the truth as you understand it, and keep seeking that within the context of the church, it's very good. I'll stop there and happy to take any questions or comments. Thank you.